My name is Ritesh Kotecha. I'm an assistant attending physician at Memorial Sloan Kettering Cancer Center. I'm a GU medical oncologist with a clinical and translational research interest in kidney cancer. I received a Kidney Cancer Association Young Investigator Award in 2020, and the intent of the award was really to fund population-type genetic research that we were conducting at MSK. We've known that there are disparities between certain race and ethnicity groups, and some of that is due to socioeconomic factors, healthcare delivery, healthcare access, and issues that are hard for us to really navigate. But at the same time, we were interested also on the genetic side, and are there actually fundamental differences, particularly in some of the cancers that arise in these patient populations themselves. From our standpoint on the grant, we looked at particularly HLA, or human leukocyte antigen, which really tells us a little bit about the immune system, with the idea that there might be certain HLA differences between these groups and the types of cancers that we see arise. And we linked the specific cancers with genetic ancestry, which is a different marker for almost a genetic surrogate for a person's race or ethnicity. And what we found was that there are some inherent differences, particularly between African ancestry patients and European ancestry patients. And those differences didn't actually even correlate beyond just survival differences, but we actually saw genetic differences, particularly in the enrichment of specific cancer mutations that arise in the kidney cancers that are found in those populations. That tells us a little bit about what are other factors that might be actually underlying some of the differences that we see in not only patient response, but also patient outcome. We were able to publish these findings in Cancer, which is a journal, and this detailed a retrospective review of about 1,000 patients that we saw at MSK and their cancer tissues. We are continuing to some degree some of those efforts by expanding that. One of the inherent challenges by doing these types of retrospective series is, even though it sounds like a lot of patients, 1,000 people, you can imagine that there's a very small number of patients that actually do have some of these minorities, particularly African ancestry, East Asian ancestry, South Asian ancestry. And so really trying to understand if we can increase those population groups and see similar type findings, that's really what we're now trying to do. I think we're always trying to optimize the types of treatments that we give our patients, and really trying to get to a point, particularly in the field of precision oncology, right? Are we trying to understand what's driving these types of cancers to respond to certain types of treatments, and can we sort of fit better keys to better locks? And I think in this context, the whole overall goal of the project was to understand what are the different locks that might be in these types of different populations, and should we be actually a little bit more cognizant about specific features that we see in a specific patient population compared to another. So in our research, we started to look at, for example, metastasis patterns. Do patients, for example, that are minority, do they present with actually more advanced disease? What is the aggressiveness of that disease that we see in that patient population? And I think understanding that and capturing that from a biomarker perspective can help us understand a little bit more about how to be more precise about our treatment. Patients that are diagnosed with brain metastasis and kidney cancer represent a really, really high unmet need. Many patients that are diagnosed with brain metastasis are not able to participate, for example, in clinical trials, where we're really trying to revolutionize, let's say, the field. And so access to potentially sometimes medicine, and more importantly, the really high morbidity and mortality that can really be accompanied with brain metastasis. In kidney cancer particularly, you could imagine any type of brain metastasis insult could really lead to even neurologic, really devastating type outcome. And understanding if patients with brain metastasis should be, number one, treated in a specific way, particularly with combinations of systemic treatments, local interventions, particularly with surgery or radiation. How do we actually pair some of those mechanisms together to really get a successful outcome? In one of our studies that we did, we actually performed at MSK a retrospective review of multiple different clinical trials in a multi-institutional collaboration. And we looked at patients, for example, who were diagnosed with metastatic kidney cancer, were screening for a clinical trial, however, were found potentially at screening to have a presence of a brain metastasis that may have been even asymptomatic. And we know that that number is small, it's about less than 5% or so, but you can imagine that a patient that has an asymptomatic brain metastasis may want to have some type of different treatment modality added to their systemic therapy. And so now, because of some of that work, we do really emphasize screening, particularly with MRI or a CAT scan, the brain when anyone's diagnosed with metastatic disease, to ensure that we're not missing some type of disease that we should be actually potentially treating in a different way. We've also instituted at Memorial Sloan Kettering an investigator-initiated clinical trial to evaluate brain metastasis as well, treated with cabozantinib, nivolumab, and radiation, with the idea that this is a group of patients where we really don't have a clear sense of what is the best kind of modality that we should be using with these patients, and there are so many different other aspects of care, particularly from their neurologic side, steroids that are used particularly for edema that's associated with brain metastasis. How might that be affecting treatment? How might some of our treatments actually help with functional even recovery from the brain? That's what we're trying to evaluate. So when I finished fellowship at Memorial Sloan Kettering, my goal was to really try to become a good clinical and translational researcher. And I think that the oncology field has really accelerated, where you almost can't escape a lot of this biology that kind of drives a lot of innovation within the field. When you finish fellowship though, it is really hard to understand exactly where you're going to sort of potentially carve out some area of expertise, number one, within a group. And more importantly, really how do you get yourself some footing? And that could be protected time, that could be some high risk, high reward type project where you say, I need some money to actually just see, is this going to be a signal that we should investigate further or not? And you can imagine that larger grants, for example, from the federal level are very highly publicized. The Department of Defense, KCRP program, the NIH has programs. But there are also organizations like KCA that really are able to give young investigators a chance to have some initial funding to get some of that footing to really try to propel their career forward. Because this type of funding is really crucial for young investigators to really try out concepts that are new in the field. And organizations like this that want to fund new ideas, new ways to evaluate biology, even potentially new seed kind of ideas to test novel therapies, in preclinical models. Some of that stuff really requires, on other funding mechanisms, a lot of preclinical data, right? It requires almost a litany of just background to really say, is this a concept that we should explore or not? And I think here, not to say that a lot of the concepts might be only early funded, but it's organizations like this that can actually kind of put some backing into some really innovative, cutting edge ideas to bring to the field.